This is a topic of really intense interest. It's a basic operation that we're all trained to do, and I'm not here to be critical of any one of us, but it's often it's a very complex operation, quite frankly. It's not often done well with regard to getting the information that we all need to take care of the patient in front of us. So what I've constructed here is just a risk stratified approach to TURBT, and we can use the term personalized surgery, if you will. So these are my disclosures. I'm not really talking about any drugs, and I don't have any relationships with any technology companies. If there is something that I see, I'll point it out. Okay, so these are AUA guidelines. I trust everybody's familiar with it. It's worth going over again. And in the blue are the things that we need to determine objectively. Tumor size, all of us know that drives which CPT code we use, and that's how we get paid. Measuring tumors is not an exact science. If you're really interested in actually measuring, the width of the cautery loop is 6 millimeters, so you can just kind of go across the tumor for that. And I actually measure after the resection. I'm looking at the tumor bed, and then I document that in the operative report. Complete resection of all visible papillary disease when we're dealing with a non-muscle invasive cancer is a priority task number one. If you look at perioperative chemotherapy trials, if you look at the control arm that didn't get the drug, the recurrence rate in the first 6 months is due to missed tumors. We all miss tumors. There's enhanced cystoscopy techniques which help us find those, but we all miss them. I miss them. And then in the case where you've got an unexplained positive cytology, we see this all the time, right? The bladder, 80% of the time, is the location for that, but you also have to think about extravesical sites, prostatic urethra in the male, upper urinary tract independent of sex. You have to memorize this. I actually am more in favor of the EAU risk stratification. The only real difference is the small TA grade 3 tumor, 3 centimeters or less. AUA guidelines put it in intermediate risk, and I do treat some of those patients like intermediate risk, but the EAU puts those in the high risk category. And while I think low-grade T1 does occur, it's a rare event, and oftentimes it's called T1 because it's growing into the stalk of that papillary tumor rather than really into the established lamina propria. Next slide. Re-resection. So go ahead and click through the animation. There you go. Repeat TURBT would only be necessary in that first guideline statement if you've got an incomplete resection. One of the things that I actually don't think I mentioned in this talk, here we go, is that a lot of times, BCG shortage, for example, or logistics, or complication from surgery, you can't really start therapy within that 4-week window. We actually prefer to start within 2 weeks. But if you've got someone outside that 4-week window, and I'm not talking about CIS, but papillary disease, just scope them in the office before you get started and make sure you got everything and make sure that there's no fast regrowth of tumor. And then whether or not you need to re-resect the patient with a non-invasive high-grade cancer is not an a priori requirement. However, oftentimes we're looking at that and we think it's a low-grade tumor, so we don't do bladder biopsies to look for CIS, or maybe we don't have enhanced cystoscopy techniques, but you get it back and it's a high-grade TA high-grade, maybe large volume. Take the time to take the patient back to the operating room and add those site-directed biopsies to determine whether or not there's carcinoma in situ. Don't ever skip the step of re-resecting a high-grade T1 patient, period. You'll never make a mistake. Is it across the board 100%? No. The Europeans have presented data to suggest that you don't necessarily need to do it in all patients, Maybe the 85-year-old that lives 3 hours away that, has this small T1 high-grade tumor, okay, fine. But for the most part, please don't skip that step. You really will never regret it. Okay, so now let's crank through the risk stratification. So low risk, first occurrence, small volume, TA, low-grade tumor, very common. We all deal with it. Cysview is, fluorescent cystoscopy. Just a hand raise if you have any experience or have the technology available to you. Interesting. I realize that this requires a Storz system, and that oftentimes is a barrier if you're using a different company. If you are a Storz user, I would strongly encourage you, if you're taking care of these patients, to learn and get access to the fluorescent cystoscopy system. I used to have a consulting relationship with them. I did the clinical trials. I haven't been involved with them for a long time, but I'm a huge fan of this. I'll show you one example as we move along in the talk. So it's very helpful to identify those other small papillary tumors. TURBT only. There is no indication for doing site-directed biopsies in a patient with a low-risk tumor, period, unless you, of course, see something, right, that's suspicious. And then the standard of care is a single-dose perioperative chemotherapy. Level 1 evidence. We used to use mitomycin. We now use gemcitabine because of the randomized clinical trial that was done in the Southwest Oncology Group, published in JAMA. We should all be familiar with that. The nice thing about gemcitabine is it's not particularly toxic. So en bloc TURBT. Anybody done this before? Okay, so why should you do it? Because why should you consider doing it? This is good for tumors probably up to about 2.5 centimeters. One of the tricky parts, if you actually do it on a large tumor, it's hard to get the whole specimen out through the resectoscope, and then you end up resecting it, which kind of defeats the purpose. And so for smaller tumors, the nice thing about it is you get that en bloc interface of the tumor and the underlying stroma. The pathologist loves it because they can give you very precise, very accurate staging and depth of resection. For you golfers out there, think about it as a sand wedge, right? The wedge is not supposed to touch the ball. It goes underneath the ball, carries the sand with it. Same principle, a bunch of different ways that you can use it, or you can do it. Now just advance one. Okay, so I'm using a Collins knife electrode. You're all familiar with this. I'm just going around the periphery of the tumor you can use cutting or coag, just to define the limits of my resection. And then you just really, I kind of teach the residents, I said, think about this as a pair of scissors. You're just kind of spreading, dissecting, pushing. So once you've got all the border defined, and the tricky part is you'll see getting this off the back. So I'll just turn it around, I'll push. Now, I've gotten full thickness into the bladder doing this, and that maybe is the only downside. Maybe I'm just not that good at it. So oftentimes in this case, or maybe not this particular case, but if I get that deep, unfortunately, I'm probably not going to give him a chemotherapy drug. And that may be one downside. And then, of course, you got to leave a catheter in for a couple of extra days. We can go to the next slide. But it's a pretty easy technique to learn. Obviously, we're all familiar with the instrumentation. Intermediate risk, multifocal and or recurrent, again, TA low-grade disease. Again, TURBT only. You don't always know that it's low-grade, so get a cytology in the office when you do your diagnostic cystoscopy. And again, en bloc resection, and then again, the use of Cysview. The standard of care is either intravesical chemotherapy. In our hands, we use mito. We also use gem. BCG has an indication, but please don't use your BCG for these patients. The AUA put out guidance on that, and I hope none of us are using it and preserving the BCG for the high-risk patients. Next slide. So don't click yet. Don't do that. Thank you. So high risk, again, any patient with high-grade disease, the exception for the AUA guidelines is that small 3 centimeter or less TA high-grade. I like to get a biopsy in the office. It's really easy to do. You just take your flexible biopsy, forceps biopsy the tumor. If you know it's high-grade, Then you're going in, you got to get muscle, you got to do site-directed biopsies to look for carcinoma in situ. We use CysView in every single one of these patients. And then treatment, of course, is BCG. Advance. All right, so this is actually the demonstration of CysView, and I hope this projects well. This is a patient who actually has done beautifully, but you could argue that you would see this on white light, but the blue light and the fluorescence cystoscopy really helps define the potential extent of carcinoma in situ. This happens to be a tumor in a diverticulum, which we were able to resect and re-resect and get him tumor-free, and he's been on BCG, and I think he's done really well now for at least a couple of years. BCG Unresponsive, I'm not going to, the definition is published. It's essentially patients who have at least 5+2, induction plus 3 months maintenance, and recur within a 6 to 12-month period of their last BCG, the exception being if you have a high-grade T1 tumor after induction only. You must sample extravesical sites in these patients because you can clear the BCG in the bladder, but the prostatic urethra is a reservoir for CIS, and you have to sample it, otherwise you're going to miss it, and then the next thing you know, you're going to be dealing with a prostatic stromal invasive cancer with a very different outcome, and the treatment is too much for this talk. Next slide, please. So staging the prostatic urethra in patients who have recurred after BCG, so this BCG unresponsive patient population, understaging the prostatic urethra has profound negative impact on overall survival. These are survival curves. So you have to get it. Now, what do you do if you find it, right? So that patient probably has an a priori indication for cystectomy. In the non-cystectomy candidate patient, you can do a full TUR to resect the bladder neck. If you've got a second-line intravesical therapy that you could use, and obviously we have an FDA-approved indication for pembrolizumab and hopefully more options coming down the road. But don't forget to sample the prostatic urethra. Next slide. This is how you do it. It's a TUR at 5 and 7 o'clock adjacent to the verumontanum. These slides show that that's where there's the highest concentration of prostatic ducts. That's where you're going to find CIS. It's never visible. It always looks clean as a whistle. I'm not talking about the tumor that is at the bladder neck and invading the stroma from that side. This is different. Yep, and there's the guideline statement supporting that. Next. Okay, so muscle invasive bladder cancer, and I've used this slide for really quite a long time. If you've seen my talks before, you're probably sick of seeing this. But the idea is getting all the information that you need in order to be able to make decisions about how to treat the patient with muscle invasive bladder cancer. Again, sampling the prostatic urethra. I'm a huge advocate of this. Not everybody supports it or agrees with it because I use that to help me plan the urinary diversion. And of course, if I'm not going to do an orthotopic neobladder, to know if I need to take a lot more of that membranous urethra in order to get a negative margin. Next slide. I sure wish I could advance. Just click through this. Next. Great. Okay, so we're on muscle invasive bladder cancer risk factors for locally advanced or occult metastatic disease. Everything except the von Rundstedt slide on the right is from a wonderful MD Anderson study in collaboration with USC. The von Rundstedt study is, Fritz and I did this looking at our own patient population, essentially found the same thing, that these risk factors for recurrence or perhaps occult understaging would be a 3D mass, so that would be equivalent of a T3B patient, extravesical involvement or adjacent structure involvement, lymphovascular invasion, hydronephrosis, which increases the risk of extravesical extension, and then aberrant adverse or variant histology. If you don't have any of those, you're in a low risk category and you do much better. Advance. So MRI, I think, in the future is going to be probably our preferred staging tool. It's coming around, and there's a VIRAD system that we participated in. Think about it as PIRADS for bladder cancer. And there's very well-defined criteria on MRI for staging, not a perfect system, but you can see with pretty high AUCs on the bottom left. So the idea is, here's conceptually how I think about this with muscle-invasive bladder cancer. So most of these patients, I'm not doing the primary diagnosis. They're referred in. We're very appreciative of that. But I always restage the patient before making any decisions. It's not that we're necessarily worried about the diagnosis of whether or not they have muscle-invasive bladder cancer, but oftentimes I want to sample the rest of the bladder. Oftentimes in a male, I want to sample the urethra. Oftentimes in a female, I want to sample the bladder next so I can think about ultimate reconstruction if we decide to do radical cystectomy. And then if we're doing neoadjuvant chemotherapy, I'll take them back to the operating room to restage them again, because essentially those options are back on the table and it really helps me plan surgery. But the question is how accurate is it? And I think one of the problems, and here's a statistic you can kind of stick in the back of your head, is that in patients who are CT0, so you do your resection and it's clean, great, we've got a clinical complete response. Dr. Hamstra just showed you lots of data about some of the pitfalls of that and the need outside of a clinical trial usually to go on to definitive local regional therapy. Basically, these data all show the same thing, about a 25% probability of residual at least T1 high-grade cancer. And also remember, we're going to do a thorough node dissection. So you could have a CT0 in the bladder, but you could be PN positive. And you wouldn't know that if you're not doing a cystectomy. Even PET-CT is not going to pick up these small little areas of metastasis. Dr. Hamstra can talk circles around me with respect to bladder preservation, but we are really very enthusiastic about offering this to, appropriate patients. And I think what you're seeing in the field, urologists are starting to sort of think very seriously about this and embracing it as an option. All you need is to do a cystectomy on a patient, let's say neoadjuvant chemotherapy, do a cystectomy, PT0, PN0, and they're dead from a PE at 3 weeks. And I've had this happen. I think everybody who does this operation has had this happen, and you start scratching your head going like, what did I just do, right? But again, I just preface this by saying we've got problems with clinical understaging, and that's why we do it. But in that setting, even after neoadjuvant chemotherapy and this restaging, we're keeping that option on the table. Now, for the clinical trial, neoadjuvant chemotherapy is not allowed. This is the SWOG-NRG trial. And I simply put this up this sort of a treatment planning slide on the left. And on the right, if you look at the bottom right, this would be the result of a maximal or a complete resection. Now, I'm not talking about the patient with a 5 or 6 or 7 centimeter big, huge tumor in the bladder. I'm not trying to, there's no way to resect all of that. But I'm going to try to maximally debulk as best I can. Next slide. And here's some data. I took one example of a maximal TURBT. There's lots of references there if you choose to get into it. Scott Delacroix put this together. Scott's a great collaborator from LSU in New Orleans, and you can see the Kaplan-Meier plot, difference between maximal TURBT and not maximal. But quite frankly, that could be driven by tumor size, could be driven by hydronephrosis. There's a lot of other factors in there. But if you're contemplating bladder preservation, okay, chemoradiation therapy, or even palliative radiation, really consider doing a maximal TURBT, and it could potentially even involve a second trip back to the OR just to make sure, that you've got it where you want. What I've tried to give you a framework of is a risk-adapted and non-muscle invasive disease, a treatment-adapted approach in muscle invasive. This study that Dan mentioned that's being done in the UK by Jim Cato of an MRI, a biopsy, and hit the go signal with usually, I think chemotherapy is what's embedded in that trial. There's some risks in that, right, of over-treating. Jim's idea there is just to minimize disruption of the primary tumor. But also in their system so that they're not delaying initiation of treatment. In our system, it can be several weeks, quite frankly, even with the multidisciplinary team being in the same place. So something to sort of pay attention to down the road because we're pretty good at doing a couple of biopsies in the office. So I hope this helps you when you're kind of got the patient in front of you, and I look forward to the discussion of the cases. Thanks again.